Morning, everyone. It is, we'll call the meeting to order for Monday, August the 11th. Provision of pecuniary interest. Anyone having any, please forward it through to Paul if you have. Minutes, we have the minutes for June 12th meeting. And also for the closed session minutes of June the 12th. Do we have any errors or omissions or business? Seeing none, moved by Kathy, seconded by Mike. All in favor? Carried. We'll get right into our action items, and the first one is the WSIB liability growth. Bill, I have you now.
Yeah, Paul's just gonna put up a little.
No problem.
Maybe.
Maybe.
I can't minimize when we're doing it this way, so.
I don't have a gavel for you.
Oh, yeah, no, yeah, perfect. Thank you.
I don't have to gavel.
Travel gavel.
Okay.
Gravel, yeah.
Travel gavel.
Can you see that, John?
Yeah.
John's muted.
Oh, okay. All right, so Brian, what we're doing here is we're giving you an update. The board's seen some WSIB statistics before, but I asked, the information was old. And it was a couple years old, so I asked for an updated actuarial assessment of where we are with WSIB. And the basic story is it's getting progressively worse. It was bad before and it's getting progressively worse. It's not a runaway train yet, but that's why we're having this meeting, is so we can put the brakes on a little bit of the train and plan for the train to be moving a little faster than it was. So one of the recommendations I have, based upon just how fast this is changing, is that we're gonna get this actual evaluation done every year. And also make sure that you get quarterly updates on where we are with how much we're spending in WSIB. I think there's a couple of major takeaways, and we just put these up on the slide for you to highlight just how much of a change we're seeing. But that liability grew 33% since the last report, which is pretty big. I can give you definitions for all of these, like what a layman's term for all these non-actuarial things are, but that benefit expense rose quite a bit. And here's why: a lot of claimant counts are going up, and then longer durations of these. So we have a lot of, as you know, our demographics is kind of U-shaped. So we have a lot of younger employees, and we have a lot of folks that are later in their career. And when we get some of those young employees on WSIB, then the potential length of those is pretty catastrophic to the WSIB account. So in force means people that are actively collecting from the WSIB account. You can see that went up by 8 people, just in that, since the last report. That's year over year, right? So the last report was a prediction of a couple of years ahead, and this is like year over year numbers I'm giving you. And the PTSD is the number one factor that's influencing this. We kind of knew it. Several years ago, Brian, we knew this was going to have an impact. I just don't know that the actuaries or us predicted the impact would be this high. There's a stat in there called actuarial gain or loss in a year, and it's in that chart. And that number is, we'll keep going. Yeah, there it is. You can see what that number means is, what did you predict your costs were going to be versus what were they? And you can see that, we're not losing as much compared to our guess in actual gain and loss, because we're getting closer to guessing right, but we still can't even keep pace with what that guess is. And we're off by, so this year our guess was off by 1.63 million. So it's not for a budget of our size, it's not a non-substantial amount. Eric, you okay?
Not streaming.
No,
Yeah,
that's
me.
okay. We're gonna tape it.
Is it recording?
Yeah.
Oh, great, thank
Yeah,
you.
we're good.
Sorry about that.
No problem. So, yeah, so some of these numbers, like that accrued benefit liability is the amount you officially owe for all your claims adjusted for the accounting rules. So that's like your discount rate. That benefit expense line is the total cost you recorded for the year, including new claims and interest and any past actuarial changes. We haven't really changed any of the assumptions, which would be something you might ask, is like, did you change assumptions to get to these numbers? No, these are the exact same assumptions around the discount rate and everything else. The employer benefit payments, that's the actual cash paid out to WSIB claimants during the year, and you can see that there's been a significant change there. So, what we're, if we go one more, Paul, what does it say? It says that, yeah, so the liabilities expenses rose significantly year over year. We're gonna continue to see these types of changes. Anything we thought from PTSD legislation is material, but it's more material than we even thought, even we guessed at. And I think what the trend line is suggesting from our colleagues around Ontario is that this is gonna continue in this direction at this pace in 2025. And so we have to prepare, we've given the board already some ideas on what we're doing. I would say that there's 7 things that we can do to mitigate WSIB costs going forward and to give new opportunity for return to work, and we can speak to those if you like, but mitigation is a high priority because we have to turn this train around, or you won't be able to sustain this type of growth for much longer with the size of budget you have. We can't continue to be off by that much.
Cass?
Yeah,
No, are you done?
I think so, yeah.
Just back to that screen, when it says about the legislative, no, the next one, the first, the third, the one after this, the observations. Legislative impacts. So like Bill, you said, and I think we all agree, like this can't be sustained, and we cannot be obviously the only paramedic service that is experiencing this. So when it comes to legislative impacts, is there anything that can be done collectively as emergency services, advocacy, anything? Because like as I say, this is it's not just impacting MLPS, it'll be paramedic service, emergency services across the board. And there has to be an understanding by higher levels of government that these impacts, like there's more than just, you know, changing legislation. It affects our services without, you know, benefiting the service to the end user.
So I haven't heard of any political movement from management teams in fire, police, or ambulance trying to get legislative changes to that legislation. Adam, have you?
Sorry, not legislative changes. There are additional initiatives that are being done within the paramedic sector. The paramedic chiefs are working towards or lobbying for more unified resources that would be there, and you'll see some of that through SolGen, for example, just released money for first responders, but that money is not just earmarked for paramedics, unfortunately. With that regard, it's for all first responders, including police, fire, and corrections.
Which would be
We're starting
helpful.
to see some of those initiatives that are
It
coming
would be
out.
helpful because mitigation funding of any kind to help with some of the, so like as you know, we're doing a lot of things to try and mitigate the WSIB impact here. And frankly, I think we're a little late to the game here in terms of that. I think some of our colleagues around Ontario have had better return to work plans and better initiatives before, but hopefully we're gonna pass them here soon because we've got a lot of things that we're trying to do to help out with those on WSIB, a lot of things we're doing. And so right now, the best we can do, I don't think lobbying is going to impact the legislation. I think all we can do is try to give better opportunity for those that are on WSIB to return to work, new experiences to come back to work, and to continue to carefully monitor the financial impacts. And that's about all we can do, and communicate to, as you said, not only to the province, but our other funders. Like when we go to whenever they see what our percentage increase is in our budget and they go, whoa, why is that? Well, hey, you know, on a budget of whatever our budget's gonna be next year, this is a pretty significant amount of new WSIB costs. And we have to not only plan for this year, we have to plan for those future costs as well. So yeah, it's a tough one. I don't see anything politically about that legislation changing.
Fine.
So I basically have one question, but I want to break it down into a few things so I can be clear. So paramedic services as first responders now have presumptive coverage PTSD through WSIB, correct? Which is good. So when we look at our PTSD claims prior to the presumptive coverage coming in compared to what it looks like now, did the presumptive coverage concept make a difference?
Oh, yeah. Yeah, so it's like substantial.
So that's one of the things.
But I would change the word to massive, like, because there's a huge difference between when you have to go and get.
I'm fully,
Yeah, you're fully aware, it's a
I'm
huge.
very
difference
aware
between the
of
two.
all of this, yes,
Yes,
certainly.
and plus, I always say to everybody here, Mike, this is probably the most difficult public service there is. The number of times you have the opportunity to be in a PTSD situation is pretty high compared to almost every other services out there, so it's not only did the opportunity change in terms of the legislation, but also the number of factors that we have is just increasing every day. at paramedic
So-
service.
My next thought is across the province, as PTSD coverage, presumptive PTSD coverage slowly came in, police to fire to EMS and corrections and.
In that order.
Yeah. So as that has happened over probably the last 15 years,
Yeah, that's a good number.
I'm just wondering, has it created a silo effect? So the police were first to get it, and they started to deal with it within the policing community through the PAO, so Police Association of Ontario, union representation, and Toronto Police Association, the Ontario Police Association, and then you have the Ontario Association of Chiefs of Police looking at the administrative side. So I'm sure that creates a silo, and then it went into fire and pretty quickly right over to EMS. So I'm wondering if all of these first responding agencies are working inside of a silo, trying to mitigate budget implications. And perhaps what needs to happen is all first responders at their upper levels of associations and administrative levels start looking at this from, we have a PTSD, mental health has changed dramatically over the last 20 years, which has led to all of this. So how do we prevent this from happening as opposed to dealing with the aftermath as it happens? And I know we have a strong program here, but having a strong program here may not be benefiting everything else across not just our sector, but the first responder sector. So it may be time to try to figure out how to get boards involved and bring this to a higher level. Because if we do that, then I think we can start to get money from the federal and especially the provincial government. If we're saying, here's a program, it's going to have to be well-defined and well-researched, but here's a program that we think can mitigate people getting PTSD somehow, some way. We don't want people hurt. Let's keep them from getting hurt. The ones that are hurt, yes, we have a mitigation strategy to try to get them back to work earlier. That helps our budget, helps them personally, or I would say it helps the employee far more than it helps our budget line. Yes, it does help the budget line, but it's not good for employees to be sick and sitting at home. That in and of itself is causing way more, I believe, way more mental health problems than the PTSD is. So it's good that we have that plan in place, but how do we bring this to a larger conversation?
Yeah,
Is what I would.
so the province, when they introduced the legislation, Brian, they did some work on trying to do that, to have an umbrella group that would look at how to respond to PTSD challenges. And maybe what we'll do is we'll at another opportunity, we'll send the board around information on what those opportunities are, but they're more general, like you're talking about, but you're talking about being even more specific across the broader sector, about all the different sectors working together. This is more informational and like.
Yeah, and I think it really has to come to how do we get into a research paper about what is causing the problem? And then how do we mitigate it so that people aren't being exposed to this, or if they are being exposed to it, and we know they are, that there's a program that can help mitigate this from turning into PTSD. We're waiting for the health emergency to occur and then saying you got PTSD and we have a program to help you. And that was definitely the first step. It had to be the first step. So we've got that step in place. Now we need to go right back to the beginning. When a first responder appears on scene, we should be able to have administration say there's a program that these people immediately need to be involved with to not let this turn into PTSD, so that it's immediately trying to be dealt with.
Well, that's what we'll do, I think, for the next opportunity is we'll give you not only what are we doing here, but Adam hinted at or started to talk about sort of January this year, I think it was, Ontario's initiative for the first responders, and we'll give you some more information about what they're trying to do. I think our big concern, I think there's an effort to do what you're describing. My big concern, and I think Adam shares it, is there's just not enough money in it. It's like just spreading the margarine over a whole loaf of bread. It's really not gonna be enough to get to where we wanna be, even within our own service.
So how do we get that money?
Lobby.
So where does that come from?
Yeah.
You hit the nail on the head. Like, for example, here, when you're talking about a lot of services can be reactionary. So not just paramedic, but a lot of emergency services, so that there was a critical stress injury. And there's efforts to put things into place to help that employee get them back into the workplace, reintegrate. But what do we do for the individual when they suffer or they're exposed to a call? So we here have an early intervention program where a clinical psychologist gets involved for those higher acuity calls to help mitigate the potential for further damage down. We've implemented resilience training, but these are all newer concepts. So how do we get that to the next stage and get the other services in the province to take note? For example, the program that Bill was talking about, there were multiple agencies that all deliver different kinds of healthcare. There's Wounded Warriors, Boots on the Ground, CMHA. They all came together under one and created the Warrior Health Network, which is what the province gave the contract to through Solgen, Solicitor General, for the disbursement of that money. All the paramedic services can apply to it, as well as all the police agencies and the fire, but they have a huge list of the different types of programs, and this, which is great. Some of them are no cost, others are significant cost. So as they apply, you're looking at the universality that comes to it, because if everybody is trying to recreate a wheel or where those common themes,
We won't be able to.
there's greater advancements in working together collaboratively than everybody creating their own silo where they're trying to solve the same problem individually.
And one thing I like is that they have tried to create these PTSD centers where you can go, and there's gonna be 2 in the GTA if there aren't already in place, but I mean, that's part of the plan. And I like the idea of having what you described for one for Southwestern Ontario and maybe one for Eastern Ontario, but there does need to be a comprehensive, we need to do things locally here, service-wide. And we need to do things service-wide, we need to do things locally, and then we need to do things as a group.
But
across Ontario.
we're still talking about putting Band-Aids and stuff, which needs to happen. If somebody cuts themselves, we have to put a Band-Aid on it and treat the injury. I don't want the cut to ever happen.
Right.
And we're not at that point. We're doing studies, which is great, but even if we're doing studies locally at MLPS, we have a very limited amount of data coming in. So therefore, it's going to take a long period of time to see what is going on and what works and what doesn't work. But if you take that to the emergency services, even if you took it into just paramedics across the province, you're going to have a much more data flowing in, and you're going to be able to interpret that data much quicker. Because we don't have a decade to wait. Right? We don't have budget. We don't have the money. The government, and you know, not being critical of the provincial government, but they're really right now doling out Band-Aids, different styles of Band-Aids to treat an injury. It's not going to stop until you prevent the injury from happening. So we know being exposed to these type of incidences causes an injury. How do we prevent that from happening? I have no clue. I mean, that's,
For the
But
most part,
the
the
big
process is
psychologist.
focused on the centers after the fact. They haven't,
exactly, so it's
they-
really good at Band-Aids.
well, but they've required, I guess what they have required though is that each service do a resiliency program. And so they sort of push that part down to us. But there are ways that I think we can work on that together with other people in our service to get the stats you're looking for and all the other things you're talking about.
Yeah.
Because we have Adam can talk about the resiliency training program that we have here. But I agree with you, that hasn't been the focus at the provincial level, other than to say legislatively, you're required to have these things. Do you want to just talk a little bit about the resiliency program?
So we have, so if you recall, with the board, we did put this into place, we identify that as exactly as you say. We have or we can put all of the processes into place at the end, which is absolutely necessary, that when we have somebody that suffers a critical stress injury, that we're there able to help and support them. But then what do we do in the interim before these injuries happen? So it's better for the employee, it's better for the service, it's better for the budget, for all of those reasons that you explained. But exactly like you mentioned, this is not something that is common. There's not a lot of those resiliency programs and training that are there, and because the idea is so new within that, we don't have a lot of the information to put out there. If we had multiple services that were following the same path and were implementing resiliency training with the paramedics early on, I think that we would be able, as a group, as a whole, from paramedics, and even the same thing with police and fire, for that example, we would have more information to draw on. So if we were to go and look at our own internal workforce with resiliency training, it would take a long time for us to get the information to show the benefits of that. We know that, we can see it from other agencies, from where we bring this from, but the Ontario government, in order to fund it, is going to want to see it right here and how that's it.
Well, exactly, that's
And
exactly what I'm saying. We gotta get bigger thinking.
and then even within the paramedic service, we also run into a challenge too. Like, where do we end up looking at when we're onboarding our paramedics? Where do we identify issues and how do we supply the particular types of training? So what is the information that we can do? There's testing that police can potentially do to help identify where there might be areas of stress, and then they can shore up some of the training and education that goes with it. But paramedics services don't necessarily have access or don't have the abilities to do those same things. So we need to be conscientious and monitor more or very closely as we're moving through the career path of a paramedic to make sure that we have all of the different resources available to them throughout that process.
Yeah.
But it takes a lot of effort and a lot of
But
people
if
working
we can
together.
if we can convince the provincial government that your money is best spent doing the research now at the highest level.
Mhm.
So that this injury never happens, right? So I'm sure the labor board did this at one time and they came out and said, everybody's got to start wearing hard hats. So we prevented the head injury from ever occurring, or the potential is, right? That's what we need to get to. What can we do before anything happens that will prevent, to the best of our ability, the head injury? And I'm referring to the hard hat.
Well, let
No.
us come back to the board with a strategy on that.
It's a really big conversation.
Yeah,
Susan.
I was just gonna say, I know the OAPSB is talking about it, the Ontario Association of Police Service Boards, because it's having a big impact. And really, the municipalities are bearing the brunt
All
of
of
these
it.
costs, right? So how do you motivate the province to save the municipalities money? It becomes a little bit challenging too, so I think there's lobbying to be done on the part of the
in
municipalities.
this case, we got a good argument because they pay 50% of the costs. But the real risk is on municipalities, because when we have things outside the line that we haven't predicted and we can't pre-budget for, then it falls upon the funders to come up with,
Yeah.
without a 1 year
Well, it's
way.
50% for paramedic, but it's 100%
Yeah,
for
for
fire
fire,
and police.
yeah.
And so it is predominantly municipalities, and how much is the mental health and addiction crisis in the population impacting the
For sure.
PTSD of our first line.
So we'll come back with some of those thoughts, Brian, at a future meeting and look at what we can do as a group. But today's message is that you're also at our budget meeting, you're gonna hear a lot about WSIB mitigation strategies. And just funding of the WSIB reserve and what it looks like in our budget for next year.
I just wanna say thanks for doing all the work that you're doing to try to be proactive on this, because it's gonna make a difference.
Yeah, and we'll go over sort of all the proactive steps that we're taking now, and we're happy to do more. This is something that if there's other people out there doing something that helps, we're all for it, because this is a win-win-win-win. This is one of those
Yeah.
5 wins I always talk about. Even if we get 4, we'll be happy.
That's good work you guys are doing, there's no doubt, I was never trying to be critical of it, it's just.
Yeah.
It just needs to go up higher again.
Yeah,
And when you're in it and doing all the work that you're doing, it consumes you as people, right? As workers, it consumes all your time, so.
Yeah.
You know,
Yeah.
it might be time for the boards to get together and say, we really have to push at the highest levels to say, this is where your money needs to come. And then honestly, it probably needs to go over to some sort of a university research group.
well, I really like the idea. This isn't on the agenda, and Kathy will laugh that I'm adding this to the agenda in my brain, but I like the idea of, ambulance service boards getting together in some form or fashion. You mentioned the OAPSB. I've known about that group ever since my OMERS days and the work they do. There's a real role to play. I know in a lot of places it's just councils, but there still are advocates at every council for ambulance service. I think there's a real role to play, as a group, if we could get that going too. It's something is on my 18-month plan too, Brian, to get something like that going for sure.
Cause unfortunately, the opposite of multiple wins is multiple losses.
Yes.
Like, it's not just financial, but it's
Yeah.
impact on
It's not just
people,
financial, it's-
communities.
But I'd love to host a group that are all board members for the ambulance service and talk about common governance issues.
Maybe next game or something.
Well, I was thinking about having a standalone thing just here where we would organize it, but we'll get further down my other million things we gotta do before we get there.
Okay. We'll move on from this report and need a motion to accept the support for information. Susan and Mike, all in favor? Carried. Thank you. Our next one, 4B is an MLPS Leadership Continuity and Development Program.
Yeah, this is just to make sure everybody knows what's happening. We have new board members, new management. This is just a housekeeping item, Brian, to see if anybody has any questions. Generally, the approach we're gonna use is this program that's not a 1-day thing, it's not a 1 meeting thing, it's not part of the discipline process. It's really part of how do we support our managers and how do we support that next generation of managers. One thing that's really exciting about the summertime is our most senior group go on holidays, and you get to see the second in commands and the third in command step up, and you get to know what their challenges are for being ready. And it's something Adam and I are really committed to, is making sure succession is that if I'm not here one day, you know exactly what's gonna happen. If Kelly's not here one day, you know exactly what's gonna happen, and succession is really important to the strength of this organization. Especially as our, we don't live we used to have a triangular, all organizations used to have this triangular setup. We had deputies and deputies and triple deputies. That's not the world we live in anymore, where our management group is shrinking on purpose and getting tighter and flatter organizational charts, which means we have to be even better at succession planning about training our folks below that, and the work Jess is doing with the Queen's course is part of that. But so is this, we're talking about this tool to try and get some real data on what employees need to be ready, and not identifying an employee that's gonna be specifically chosen, but making sure you have multiple choices as a management group and a board for what happens next. That's the ultimate goal. You should have 2 good choices, 3 good choices in every position, or else we haven't done our job. So this is the approach we're gonna use. We're gonna the first report on this is gonna come out in the spring. You see what's gonna be in there, you see sort of the approach, and if anybody has any questions, just ask us, but that's the approach we're gonna use. So I'm gonna do, what we're trying to do is have, Adam and I are gonna set the example about how this is done. And then, so Adam will be talking to Dan about doing this with Dan, and then Dan will be doing it with his group below. So we're gonna try to train the trainer type of thing on this approach. And how to constantly be working towards getting this the way it needs to be. So it's not like I said, it's not hey Dan, at 5 o'clock next week, I wanna meet with you. This is something that's a living document, a living process that we work on over the course of time. and report out once a year to the board.
Okay, thank you. Questions on that or comments on? Nothing for that one? Okay, need a motion to accept that for information. Kathy, Mike, all in favor? Carried. I did, yeah, I will next time, I'll get it. And the financial structures and stewardship overview.
This is a really general report, Brian. What we're trying to do is get both on governance and on the financial and administration is next to talk about. We're trying to start from the sort of 1,000-foot level and then work our way down. So we gave a very general report about how governance works at our last meeting. This time we're giving you a very general report on how finance works and not every aspect of it, or I wouldn't have said it's a general report, but it's generally how our finance works. Not only how the funding works, but how the accounting is done, who's responsible for what. Why are we doing that? We want to make sure we're all on the same page about the rules of the road, about how things work, because we're going to be coming to you in our administrative report and saying, here's where we think we're weak, and here's where we think we're strong, and here's the changes that we need to make to get everything in the right place. And if you don't know the rules of the road for, when I say the rules of the road, legislatively, who's responsible for what, bylaw, who's responsible for what, and corporately, who's responsible for what. If you don't know that, then it's kind of hard to have a great understanding of why we're doing things the way we're doing them administratively. So it's not designed to sort of say, this is the structure. I think that's the next report we're gonna come forward with. And one of the things that Paul and I both agree is that a new service level agreement is key next step. I want it like super tight about if we're going to, there's a couple of different models you could choose. There's a completely standalone model you could choose, or there's a contracted services type model you could choose. No matter which model you choose, we have to know who's doing what, and this service level agreement is key to that. And especially if it's a contracted model, and then also it's easier to allocate costs for that, because we know, okay, county's gonna be responsible for AR, accounts receivable. What's the cost of that? And we can quantify that. As right now, it's a little bit more nebulous, and we want to sort of get real responsibility down in place. For example, even in reporting to the province, there's some things that Adam does, and some things Adam and I do, and some things are the treasurer at the county and I do. So we're trying to get all of that organized so everybody knows who's responsible for what. And a service level agreement is something Paul and I will work towards over the next little while. And it is our goal, I think, when I look at this, Brian, I think it's okay to have a service level agreement with the county and have them do certain functions on the finance side for us. But I want to review it in 6 months after we get it in place, and 12 months to make sure it's working for everybody and that it's the right thing. And so that's something that Paul and I will work towards as well, is not only what are we gonna do, but how are we gonna review whether it's working for everybody? Because we have to think about the county who's providing that service, and we also have to think about MLPS and whether it's the right model for us. So as you saw in there, all core financial functions right now are supported by the county. There's different levels of responsibility that we laid out, but there's some that are joint responsibilities, and we kind of tried to explain what those were. But we definitely need to work on that service level agreement to improve the standards and the timeliness of reporting, because not only is the board now requesting more information related to financial reporting, as you should, but so am I, and so are our funders. Legislatively, all we have to do is, just to be clear, because now we've done the governance report and the funding report, for our funders, all we have to do really, especially for the City of London, we'll just talk about the City of London as a funder, is we have to just simply report out what our year-end expenditures were, and then tell them whether there's a surplus or a deficit. That's it. That's the only reporting requirement. But at the same time, there's a high demand to know from our funders where we are mid-year, where we are a quarter through the year. And I don't want to hold that information back. We have no reason to, but it takes resources to do those things that we just haven't built up for. There's not a finance person in this building. So that tells you a lot about, where we are for MLPS to do some of that reporting. So I think the perfect model and what we have in the budget and what I'm gonna be coming back to the board to say I'd like to implement is get the service level agreement in place with the county. But I think you also need a person here that's responsible for finances. And I don't know what we're gonna call that person yet, but you need a single brain here that only focuses on MLPS finance, all the things that are in there. So they'd work with the county if you had a service level agreement, but someone that was purely dedicated to thinking about county finances all the time. Not only reporting, because we're getting increased level of reporting at the provincial level for our specialty programs especially, but also for other 911 services, everything's ramping up. And for Adam and I think it's the size of service we are, it's like we're long past where we should have had our own person to sort of have that single throat to watch, or a single set of eyes to watch everything going forward. So, that's the oversight piece I think we need. You're gonna hear from me, like I said, Brian, we have that role in the budget. You're gonna hear from me in terms of what the board will hear from me in terms of what the skill set is. I wanna talk to Paul more about the service level agreement with the county before we go and advertise for that. And Paul and I will work on that, and then I think sometime over the next month, we'll be in a position to advise better on that.
Okay, I think you answered my question. That was a question I was gonna have. What's the time frame you think on first?
Well, I haven't talked to Paul about timeframes, and he's not doing,
I mean, are we talking?
not shaking his head,
are
but
we
I
talking
gotta
this
get,
fall.
yeah, I gotta get on it because we got,
It's not in the new year. It's
no.
this fall. It's this season.
For MLPS, the priority is now, is fairly soon to start thinking about this because we got budget, we got audit, we got our reserve questions, and we got the primary reporting seasons coming up. So maybe we won't have someone fully up to speed. That's gonna be hard to do, but at least they can see one cycle so that they can be better going forward. But Paul and I will start talking like in the next 2 weeks, I assume, about what a service level agreement could look like, because we've never had one before.
Right.
But it's necessary.
And I agree, not, the board would like to see it, I'm sure, but our funders would like to see that as well. Sure. Questions,
I
comments?
think it's a great idea.
Yeah, it's the right direction, I think, going forward.
Absolutely.
Is there any, no other questions so on it?
The only thing I'd add is in this
Yep.
report, we just linked the reserves to the MLPS budget document. So those reserves numbers have changed a little bit, but I'll send out the board the updated reserve amounts just because that's from last year's budget document, but I'll try to give you a more up-to-date one, send one out to you.
Oh, okay, you're gonna send that out?
Yeah.
I need a motion to accept that for information again. John, Susan, all in favor? Carried. Next one is the core program, treat and refer model. Adam, that's yours.
Excellent. So the core program, treat and refer model, this is another one of those good news initiatives. So similar to what we were talking about before or previously, to answer some of your questions about what is it that we're going to do. We have an opportunity here to help the citizens, help our communities, but as well as help our own paramedics as well throughout this program. So we have a lot of good that we can potentially do with this. We have multiple patient care models that are already in effect with MLPS. Paramedic services, they're legislated on how and where they will transport patients. So any patient that we encounter, we're required to transport to an emergency department. We do have a patient care model in which that we can take a patient to an alternate destination. So depending on the parameters and that they're stable, et cetera, we can take them to CMHA rather than an emergency department. So we can take them to a different facility for them to receive designated mental health care that's outside of the medical care that they would normally receive in an emergency department. So that's beneficial for the patient. It's beneficial for MLPS in that we don't bring patients to an emergency department that's already overcrowded and overtaxed. It frees up space, the ambulances back into the system faster. We've seen great success with that program, and we've had that one in place for quite some time. A few years ago, we launched another program, which is a first response unit, not the rapid response unit, but the first response unit, where we would see.
You're getting so good at not using acronyms. I just wanna. This is really good. He would normally say "roo" and "roo."
That's right.
That's good
That
at
takes a lot of practice.
Yeah.
Just saying, it's a lot of practice.
So with that first response unit, the purpose of that particular first response unit, when we put that out into place, was in the height of our offload delay issues, we were seeing a lot of calls that would be stacked into the queue. So we would have emergency calls that would be received, but depending on their severity, they would sit and wait before an ambulance would be sent. So they weren't life-threatening emergencies. They were still urgent enough that they needed an ambulance, but they just wouldn't be coming with lights and sirens. We kept enough ambulances available in the system through the deployment plan to make sure that we had ambulances going to the life-threatening emergencies. Because these calls were still waiting in the queue, individuals and patients and citizens were waiting for somebody, we were able to use this particular patient care model to send a first responding paramedic solo in an SUV to the scene to be able to assess that patient and defer them now to a community paramedic. So a community paramedic could come take over for that first response unit and then deliver care within the scope of what a community paramedic can do. This is also beneficial because that patient doesn't necessarily move out into the emerge department. And a particular note, one that we want to always emphasize, is that just because a patient is into community paramedicine does not necessarily mean that they didn't need to go to the hospital, or that there's not necessarily complex medical conditions. It's that the complex medical conditions can be cared for by a paramedic, by a community paramedic, with the additional access that they would have to a primary care physician, which a 911 paramedic would have. So this worked really well. And now we have an opportunity to potentially expand that model, which is the treat and refer model, to another section within the city, where if we look at the downtown core, so where we're taking core, meaning specifically, for example, the core of London. So to start with a smaller cohort of patients, where we take a look at, there's a lot of calls that can potentially come in from bystanders that would be not necessarily engaging with a patient. Anytime that the 911 call is generated, a transporting ambulance is going to be sent. So we're going to end up with a transporting ambulance that's there. That patient may not necessarily need an emergency department. They might need mental health support. They might have some underlying medical conditions that would confound them and not necessarily allow them to be able to go to CMEJ, but they could also benefit from other resources within the community. So we have a lot of community partners that are looking to be able to help people, but we can't, as a 911 resource, refer people to those other community partners. By allowing us, or by moving that patient from the 911 system and being able to refer them to a community paramedic, the community paramedic can look and ascertain and do an assessment as to the medical conditions that were potentially there, and then look to our other community partners, so they can either continue the care or they can be referred over to some of the community partners. This again then would pull that potential patient out of the 911 system, move them through the community paramedicine system and into a better resource where they're needed. So we end up with a patient now that would normally potentially take or be involved with 911 paramedics for a significant amount of time, can now be engaged with the actual clinicians that would be able to provide them the care that they need. So rather than going to an emergency department and waiting for hours and hours and hours to get care that's not necessarily for what designated specifically for their purpose, they can actually be put in contact with the people that they need. So through this process as well, this gives us the opportunity then to also look to keeping that particular responding unit out of the 911 system. So by us having a program like that, we are able to open up another avenue of potential work that is a paramedic work that is not necessarily into the 911. So when we're talking about being able to return people into the workplace, we also now have another pathway for people to be reintegrated back into the workplace if they were precluded based on critical stress injuries, for example, where they wouldn't be allowed to be around emergency calls for a period of time, or sirens, or there's certain triggers or escalation factors. We have the ability to offer them another pathway in which they can be reintegrated, provide meaningful work that matches exactly what they've been trained for, but then that also protects them from those additional stressors while they have a chance to heal and be reintegrated back into the full 911 system. Perfect.
Okay.
So this is I don't know if we've mentioned our conversation that we had with the city of London. Did you mention that?
No, not yet. So we've had some conversations with the city of London. And the city is supportive of that, of this initiative. We've also had some conversations with the province. The province is supportive of it as well. We've had some conversations with some of our associated agencies, though the ones that we would be working with, and they're supportive of this as well. So we're seeing a lot of support that's rallying around this. Specifically, the important ones are the provinces standing behind the program, seeing the value and the benefit that we're able to provide, because it provides additional care to the community. It provides additional relief within the 911 system. It provides relief within the emergency department, and then at the core of that, it gets the patients to the resource that they need. And then when we're looking at all of those wins from a budgetary side of that too, there's wins in that side of it.
We're pretty excited about all those wins you just mentioned, but one of the things I was looking for too was a program where all of the funders all the partners in delivery could come together behind a common cause. And clearly, the City of London administration is right behind us on this. The hospital is right behind us on this, and because I want to be able to find something, Brian, where we can do joint advocacy and say this is more that needs to be done. Because I really think this could be a pilot for other communities going forward, and so I'm kind of excited just because everybody else is excited about it too, about what it can mean for the community. Okay, we'll stop there.
Kathy.
No, thanks for this, Adam. I mean, I think that this is a great model. And to Bill's point, pilot for other services for sure. I guess my question though is, obviously the huge benefit is diversion from emergency room and not having people in emergency that really shouldn't be in the emergency room. So I can see how Ministry of Health, I can see how LHSC is on board. And then, so these community partners that you're speaking about, my only concern is the infrastructure there? I understand we're starting, in the core, so a small area, but is the infrastructure there to be able to support those that we are diverting?
So that's a loaded question. So without commenting on whether they're supportive of it, but at any given time, their funding is also could potentially be transient. Totally understand that. The important piece for us, while we have access to these, our end goal is to get that citizen, that patient, to the care that they need. And if we can do that outside of an emergency department, so much the better. If those individual additional agencies for some reason couldn't or didn't have the capacity to be able to do that within the system, we don't necessarily have to still take that patient to the emergency department. And more to it, by allowing us or by moving down this path within the treat and refer model of care, we're pushing the envelope of the delivery of paramedic services within the communities. So when we look at the tight legislation that we have within the ministry to be able to a 911 call comes in, we go lights and sirens, and we take the patient to the hospital. We're pushing those envelopes to be able to say, well, we have access to these community partners, and they were working well. Now they can also use that as advocacy to potentially increase some funding from the provinces for those, or as paramedic services, we also have the ability to start pushing to maybe we can transfer to a different agency as well.
But if those reasons, I guess the way I see it is that we're giving more options for the treatment, proactive and reactive type treatment to the challenges that we see out there every day, or that the paramedics see out there every day. But if those resources become overwhelmed or aren't available, then we can always revert back to the way it is now. Or like a patient could go back into the 911 system. It doesn't always have to be outside the system. So that's the fallback. You don't want to use that. You want them to go directly to the right resources. But I think Adam's right. This is a great opportunity for all of us to work together and say, this is a model that works, keep them out of the hospital chain, and is a model that works, so we need those resources on the field, but if they're not there, we revert back to 911. It's just another option. And it's gonna be real interesting, Mike talks about longitudinal stats. I'm really interested in what it's gonna be like if we have a group that's being more proactive in the core as opposed to reactive to what they see. So it's gonna be real interesting to see what that turns into in terms of the number of calls we get. Because if you talk to our paramedics that work in the core area, you're looking at very long, complicated complicated calls that can be a whole shift. Or they can be multiple times to the same type of call for the same person. So this is something that if we can get right and get people the right resources in the first place, so it's gonna be a huge win for our clients.
Other questions? Any other questions or comments on this?
Actually, just.
Go ahead, follow up.
Follow up on that, and this is just a comment, I mean, I can see. And I think it's something that we've said over the years as we have advocated for either funding or service enhancements is, you know, the ministries can't work in silos. We can't think of this as just a Ministry of Health issue. And it's almost, like looking for a champion in another ministry where perhaps there's a funding stream there that is more appropriate for what we're gonna see as these statistics come in.
Absolutely.
We can't, as I say, we just can't expect the Ministry of Health to be the only fund.
Well, we have a meeting
this.
at AMO where we're going to be
Yeah.
raising that exact point, right?
Yeah.
Because it's not always the Ministry of Health
No.
that has, especially in community paramedicine.
And you're exactly right. An initiative like this gives us access to other ministries. So we've got Ministry of Long-Term Care, Ontario Health, Solgen. We have access to a lot more funding streams than just the ministry.
And it's really exciting for us that it's the deputy minister, no, parliamentary assistant for long-term care. We're meeting with him and he's very excited about some of these initiatives. So it's not just always the Ministry of
Right,
Health.
yeah.
They wanna be helpful too.
Susan,
I imagine there's a win too for employee satisfaction when you're able to care for people and get them the help they need rather than be tied up in.
Absolutely. I think sometimes we know paramedics can get frustrated. They're out there to do good and they know what sometimes somebody needs, but they also feel like their hands are tied and they know where they want to get the person down the road, but they just can't.
Yeah, so
And-
one more win.
One more win. You can
Yeah.
add that onto the.
And then also, what we're trying to also get to, and a lot of the programs are put in place is if there's specialized training that can be done. So that person has extra resources to help beyond the level of paramedic training they already have. That's a big focus for us this year in community paramedicine is about how do we provide that extra training for some of these specialized situations, so.
And I imagine you're able to assign work to somebody that really wants to do that kind of thing, right?
Absolutely.
Specialized.
Yeah, we have a waterfall idea of sort of how we would prioritize the employees that would move into a program like this.
Yeah, because there's some that would thrive in that.
For sure, yeah.
any other questions, comments on it? Seeing none, we accept this one for information. Kathy, Mike, all in favor? Carried. All right, the next specialized dedicated neonatal. Adam, you have that one.
Excellent. So just as a refresher with the specialized dedicated neonatal pediatric transport unit, which is referred to within MLPS as the NICU unit. The longer title is its official title. However, NICU is what the paramedics have just come to call it. The specific unit, if we recall, began in 2019. So the initiative began with an on-call ad hoc model where a call would come in, so they would want to transport, let me go to the Children's Hospital, has a specialized team. So they partnered with the paramedic service, being MLPS, to create a unified team. We have 4 regions within Ontario that have these. So there's also Toronto, Hamilton, and Ottawa. So one of the 4, we have a very large area being all of southwestern Ontario. When we first put this team together, there was one in Ottawa, then there was one in Toronto, and then Hamilton and MLPS came online around the same time. The model that we had when it was first deployed in 2019 required the Children's Hospital's team to identify that there was a patient they either wanted to move from their emergency or from their facility to an outerline hospital or to another hospital. So for example, if they were in the NICU or the pediatric intensive care unit here and they needed specialized care, they might have to go to Sick Kids in Toronto for whatever that specialized surgery was or vice versa, taking a patient from a smaller tertiary hospital and bringing them into a larger center in order to have that care. And not every one of those calls necessarily brings that patient to London. So they might potentially have to go to Owen Sound and take that patient to Toronto to get that specialized care that they need. So it's a coordinated team. In 2019, when that model came out, it was just that one identifying factor that there was this call. They would make or connect with the paramedic service. We would arrange to bring somebody in to service the call. What we ended up doing was we pull from the 911 system to go service the call, waiting for an hour for 2 employees to come in while there was a very sick child waiting to be moved. Wasn't necessarily going to be the most efficient. So we would move somebody from the 911 system to service the call right away while we backfilled the system while they were gone. The need for this unit quickly exceeded the expectations when it was first put together. So the modeling that the service had at the time that model was put together with the expectations from the Children's Hospital was much lower than what the actual demand was when the unit was out there. As the unit started to do more and the call volume increased, we were able to secure 24/7 funding from the ministry for that. So we saw one unit deployed 24 hours a day, 7 days a week, specifically dedicated for that. So that unit is protected. It's not part of it sits because these are still considered 911 calls. But this unit is a specialized unit and it's dedicated specifically for that. So it has special governance that it's able to just respond to these particular calls alone. So we always have one that's in the system for that. Again, the success of the unit, we saw more calls continuing to come. We saw the areas get bigger, and it's not just here in London. We see Toronto having more calls and Ottawa having more calls, so their areas shrink somewhat. These units are funded 100% from the ministry, rather on the 50-50 funding model, which is beneficial for our MLPS in that these calls would be part of the 911 system and we would normally be servicing them anyhow. But having that dedicated funding model through the province requires then sometimes greater distances for the ambulances to go. So the calls were going further distances and they were taking longer to service. We also saw the increasing calls coming in through the Children's Hospital. So in our partnership with the Children's Hospital, we identified that they were also turning down calls from the tertiary area. So if they had a call, say in Windsor or Owen Sound, they would normally want to be able to take that dedicated team, send it to that sending hospital in Windsor or Owen Sound, pick up the child and bring them back into London or Toronto or Hampton, wherever they needed to go for that specialized care. But because they didn't have another team within the Children's Hospital, because they were already otherwise deployed, they would have to turn the call down. The call would be serviced by the local land ambulance that was there. So Windsor or Owen Sound ambulance would drive that patient into the Children's Hospital, but they would be doing that just with paramedics and a nurse escort that was there and not necessarily receive the interventions or the level of care that they could have otherwise had through this specialized team. That led us to being able to put in another business case to the ministry, and we received special funding, again, at 100% funding for another unit that's on 12 hours a day, 7 days a week. So we do have multiple units that are out there servicing these calls. The calls that they service that are always high risk. So the patients are quite ill and they're quite high risk. The team is extremely specialized. Our team works very closely with the Children's Hospital. So it's not just a transport unit. They work very closely together in order to service these calls and do phenomenal work. When we take a look at it, so far they've serviced just shy of 6,000 calls. It's 2019, and that's for the highest acuity of these neonatal pediatric transport. And the average age of these patients is 6 days old.
I can't even imagine a time when this didn't exist. Like if you think about those stats, and just a quick shout out to that group, Adam touched on it, but this is a proud group of people that deliver the service, hardworking, and are really well trained in this area. And it's really important every once in a while to go and meet with those folks and see how they're doing. This is a tough job they're doing, and they're a great group.
Are they housed here?
Yeah,
Yes.
They're here at the main,
at the Adelaide
Yeah.
station.
at the Adelaide station, okay.
Yeah.
I would just make comment, I remember the minister at the time was very much a supporter of this program, and I remember when it came out, I had no idea there'd be this many calls, like, it's so much more than what at the time I thought it would be.
Well, we have to keep,
It's,
the way to keep great programs like this is to keep talking about them. That's one of the reasons I wanted this out here today. But also, we're gonna be providing you with talking points for our funders about great programs that should continue to be funded. When you're meeting with AMO, or we want you to have these things in your pocket, because if they don't hear these things consistently, they forget. Because it was a great idea maybe whenever the minister announced it and we were all gung ho, but it's easy to forget when these programs get in here. But if we lose a program like this, I can't even imagine what that would be like, and we just need to keep advocating for these types of programs.
yeah, agreed. That was what my comment was. It's just the need is so much higher than what, certainly than what I expected. And I think it became higher than what anyone expected, I believe.
Yeah, I agree. I think it's just continued success that goes with it. We even see
Yeah.
now we start to see more of those calls backing up. So they'll create and pull additional teams where both units will be out during the daytime, and then there's a call for a third child. So they'll go, the team will, like from children's side of that, they'll try to pull somebody from a floor to deal with a nurse and a respiratory therapist. They'll try to put together an ad hoc team to be able to go.
That's what they would have done. That's what they would have
That's
done
what-
back in the day,
well,
like
they did.
before
Yeah.
this. That's what they would have done. And so to the point of, you know, hospitals aren't gonna wanna see it revert because they don't have the ability to do what they did in the 70s, 80s.
Yeah, it's
and
not hard to
90s,
get
right?
joint
No.
advocacy with the
Exactly.
hospitals
Yeah.
because they see the benefit and.
Everybody wants that baby with a specialized team.
And for our group as well, it is a difficult job because it's not a 9 to 5 job necessarily. You can see the number of kilometers that you're traveling, and calls late in your shift can take you far away from birthday parties and family events. And so this is a tough role, not only the job itself, but also how you have to do it. So I really appreciate those folks, but it is an easy one to get joint advocacy for. We mentioned it when we were talking to LHSC. But we really want you guys to start talking about it at your opportunities, and our funders to talk about it too.
Okay, any other questions on it? Seeing none, a motion to accept it for information. John, Susan, all in favor? Carried.
Oh, there's a video here.
Okay, the next one.
That's a movie,
Okay,
we're gonna watch a movie.
well, there is a star. It's somebody's hand, eh, Dan?
Yeah, it's a hand model.
Oh.
CP hand model.
Yeah,
George
beautiful
Costanza's
hands.
hand
Yeah,
on
George
it.
Costanza.
Yeah, isn't there one where isn't there one report before that, stable patient in her facility?
Yes.
Oh, yeah, there is. Okay, sure, yeah. Let me get this going. You go ahead.
Yeah, that's where we're heading to now, stable patient interfacility transport unit. Yeah.
So this is another great initiative that we're excited about as well. When we take a look at, when we're talking about different pathways for paramedics and things that we can do that will provide benefit to reintegration into the workplace while also servicing the community and being responsible in all senses of from a service
Sorry,
perspective
Adam,
as well.
excuse me. Hey, John, just want to give you a heads up. You're broadcasting your leg and feet right now. We stopped your video. Okay, go ahead, Adam.
We talked about hand models, now we got,
There we go.
gonna have to compete with that.
I guess, you know, he just wanted to prove that.
Yeah, he
it
really-
really
yeah,
did
yeah.
happen.
Yeah.
Write them down for a second. Go ahead.
Go ahead.
So when we're taking a look at the models and the initiatives that we potentially have, there is one area that we don't have a lot of control over immediately is when the 911 calls come in, we're required to respond to those calls. As we lay out our deployment plans, as the ministry legislates us to be able to do that, but we do not control the person who's placing the 911 call. We do have the ability within to create a deployment plan that will slow lower acuity transfers between facilities, for example. But if those lower acuity transfers, they sit and wait for a longer period of time, either they can be increased in their priority levels. So they can be increased for multiple reasons, and it could also be increased based on just the time that they would have to sit and wait. If a physician is looking to make a decision on a course of treatment for a patient and they can't get a CT scan done on that patient, it may not be urgent at the time that they did it. They can wait 2 or 3 hours, but when we get to a point where there's an hour before they have to make a decision, that patient needs that CT scan. When these calls are coming in, they're gonna come into the 911 system, and we're gonna send the closest ambulance that's gonna go to that particular patient, and they're gonna move them from one facility to the other for that course of treatment, and then potentially back again. So sometimes the patients are stable, or most of the patients are stable, but they're still gonna end up having to do this call from A to B. What we're looking to do with this particular initiative is to be able to, similar to what we see with, for example, like the NICU unit, which we just talked about, where it is protected in the system to just do the NICU calls. We're looking to be able to, or what this initiative will see is to have a unit that is dedicated to just specifically these stable interfacility transports. So before that patient rises to the level of having to be a code 3 or a code 4 or priority 3 or priority 4 transfer, where it needs to be done immediately by the closest ambulance, we do have a unit that's able to go and service the call. Let's use, for example, I'll use two hospitals, being, say, 4 counties and Strathroy. If there was a patient in 4 counties that needed to move to Strathroy for a CT or an MRI, that's going to be serviced by Glencoe, Strathroy, or Kamoka. Any one of those ambulances that move is going to result in another movement. And we do see cascading effects to that. So other ambulances would potentially be pulled, or areas would be left unserviced. If these are happening closer towards the ends of shift, where there's shift patterns, whether that's in the hospital or whether that's with the paramedics, those effects are compounded. This particular model will see that happening, protecting that shift time for the responding paramedics in the 911 system, to be able to also retain the coverage that's there. And then we also end up having another pathway for paramedics reintegrating back into the workplace. So we can again protect paramedics from high acuity calls. They're still able to come in and perform paramedic work, but it's not necessarily within those high acuity spaces they would have saw with priority 4 emergency response.
So can you just mention, we've had a conversation with the hospital about this?
So we've had conversations with the hospitals. They're excited and they're definitely supportive of that. We've had conversations with the ministry, and they're also extremely supportive and excited about the model as well. The concept is not to recreate or design like a Voyago type of system. These are calls that are coming into our system anyways. These are calls that are being placed into MLPS, into the 911 system. We're looking to assign the proper resource to that, rather than pulling an ambulance from the 911 system that can potentially do an emergency call to service a priority 1 or 2 call, or have it sit long enough that priority 1 or 2 call has to be upgraded to a priority 3. We're looking to have a protected unit in the system that will be able to service these calls in a timely fashion, keep them from getting to that level of 3, but then also make sure that we can manage to keep the 911 ambulances in the system available for the 911 calls.
If we get this right, it's gonna be another one of those wins all the way around at every level. And where the reason I wanted to make sure it was on this agenda is because we're not gonna come back to you with this again. If we get everything green lit, we're gonna go live with this as soon as possible. There's a whole pile of other advantages operationally for this, but suffice us to say that we're gonna keep track of all of the metrics about where we're winning here. And but the number one factor again is in customer service. We're gonna be providing a better support for our patients.
If I look at the numbers, they're kind of like 8 calls a day, averaging almost 8 or 9 calls a day. To this point, you're saying 1,700 already this year of those type of.
Yes.
Am I seeing that right?
Yes.
Right, so you're getting that many calls a day transferring for those type of, I know they come in at a lower level.
Yeah. So they'll come in multiple ways. So they'll come in at the lower level. To start with, if we're not able to service, so if we have a busy system, so we have a lot of calls going on, or there's a call surge, we'll see that call sit and wait, and then it will then move into the 911 system. And it'll come in as a priority 3 or a priority 4. If a patient was waiting in Strathroy and needed to be moved into London because they had to have their dialysis done, and they won't be able to wait till the next day or or a day after, they'll need to go. So there'll be a point in time where they'll make it what's referred to as a stat transfer. If it waits long enough, it could even be a priority 4. So that that call will end up into our system at one point or another. The priority 1s and 2s, they'd end up in our system anyway, so those are those interfacility transports. It's having them sit and wait for long periods of time. The additional pressure that we're potentially seeing with those is independent bodies, so independent transport agencies that are there. There's a cost that's associated with it. So that cost is either borne by the hospital, will either pay for the cost of the transport from A to B, whether that's from one hospital to the other and back or to a home. Or they'll download that cost to the patient or the patient's family themselves.
So that's where I think if there is any point of potential criticism, if you don't understand all the background that Adam's providing about the impacts on the 911 system. There is a potential criticism from a funder that might say, well, Bill, aren't you taking on something that someone else is paying for?
Yes.
And that's why this is a really important report, because it explains that even though that's happening now, this is the impact on our system, and that challenge is only going to get more as funding gets tighter at the hospital and at other places. So it's really important to have this background so we can help explain why we're taking on this challenge.
Yeah, because if they can't afford what that fee is, it will stay into the 911 system for land ambulance to do that. We're legislatively required to respond to these calls.
And that's the number one
So
answer.
we're going to get these calls no matter what.
Yeah.
We want to make sure that we send the right resource to it.
I think that's an important message to give out, that we're gonna have to answer those calls anyways.
But we can do it in a better way, a more
By doing
efficient
it.
way by being proactive with this type of program.
Yeah, and if we can do it in a way that will support our paramedics, that's even better for us. So by opening up
A win-win.
another pathway, again, for work reintegration, we have that opportunity to be able to.
But
do
let's
that.
watch the program, see what it does. We'll evaluate it at 6 and 12 months, see what we're looking at. And then come back to the board again and give you the details.
So has this started now? When do you hope to start it? That's
When you say started, you don't mean the work to get it in place, you mean like are we?
actual starting
Yeah.
to offer that to do this.
We're not actively servicing those calls yet.
Yes.
We're still working through
This way.
through this way. So we've gone through and had the conversation, or we've had our meetings with the hospital system.
Mhm.
There'll be some training that's going to be provided to the hospitals on how to actually code in these calls with the dispatch centers. We've had our meetings with London CAC. We've also had our meetings with the Ministry of Health and the field offices to get their support. We're working on the last pieces are the language that will actually end up into the deployment plan. So we've settled on all of that. So the summertime is a little slower in the summer, getting everybody back from vacations at the same period of time to be able to sit in the same meeting so that everybody can sign off on it before we go live.
And it's really important, like I know on paper, sometimes I look at these things and go, well, that seems like easy, you just take some decals off the ambulance, you do it this way and blah, 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 and you're done. There's a lot of work that went into this upstairs here, and kudos to the group that worked on this, because just getting it this far, a program, you know that in this field, things don't change, it's a cruise ship, that's not a speedboat, and to have moved it as far as we have in the summer to get this program as close as we are to implementing, Brian, is just a minor miracle, really.
So being the amount of patience that I always have on things, when do you project or hope to see this happen? Because I think it's a great program.
We're hoping for the fall. We're hoping for the fall. Everybody's supportive of
I
that.
always say Q4.
Yeah.
And if we can get it back faster than Q4, we will.
Okay. No, Kathy.
Thanks, Brian, just, I don't know much you can say, but like, so is CAC on board? And is there an understanding of how they're going to be able to
Yes,
decipher and?
CAC is on board. The only or it's not even a concern. But the one thing that CAC was wanting clarification on was potential increasing of workload.
Right.
But what we identified with them was we're not actively seeking out transfers. We're not recreating a transport service. These are calls that are coming in anyways.
Anyway.
From a CAC perspective, it'll actually help their workload rather than having lower acuity calls sitting in queue for longer periods of time. They'll actually have another resource for them to be able to assign to it. So the last piece is to work between CAC, the ministry, field office. So there's multiple ministry levels, just about the understanding of what the language is going to look like for the dispatchers that are actually sending those out. So it's crystal clear to them that you can use this vehicle whenever you need to. So we can actually keep it that way. So it'll work very similar to what we would see with the NICU unit, for example, whereas the hospitals would call CAC would already know about it and call that unit directly. And it would never, it'll still go through the 911 system, but it won't be paged out in the same manner that we're used to seeing.
Yeah, this is a good, this report is actually a good test, Brian, of the team building work we've been trying to do across all the different parts of the service. We're all one team in that chain. And like I said, the fact we got it this far through all the different groups is something that has traditionally been really hard to do because everybody has to make sure they sign off on it. So I think we're gonna get there. And we can the Q4 estimate if we're lucky. But it's something we're gonna be talking about at annual to different folks as well.
Okay. Any other questions, comments?
Just,
I took John.
Mike,
I just want to make a general comment. So at all of our board meetings, we talk about Brew and Rue and Nick. And so we talk about programs a lot, which is great. I mean, that's what we do. And, but at the heart of it all are people, right? It's your employees. And it's people. And I think there's a real benefit to sometimes going back to these units and saying, by the way, the chief brought up, or the CEO brought up stuff about your job in front of the board, and hopefully we were supportive. And you know, hopefully there's some great comments being made, because I think that bleeds down. Having been the employee previously, it means a lot to people to know that people making decisions about my job are talking about my job and supportive about the job I'm doing and supportive about all of this, which I'm now very excited about. So I'll just leave that there with.
This is this particular approach is something that that I mentioned that we have a U-shaped demographic. This is a program we talk about a lot because one of my goals as a person that's retired once already is to extend people's work life. We talk about it a lot here, how much money we put into training and education and supports. And there are folks that want to work past the traditional retirement time from a pension perspective. And so this is something that will help elongate those careers. But we also, you'd be surprised at how many folks will come up to us after this gets posted and say, hey, I saw this. We have a pretty built-in audience, but we're encouraging more people to watch the board meetings for a reason. Because they're getting us, we want them to know you better about what you're interested in, but also the types of things we're trying to do.
I just, you know, from as a board, I want people to know that we're concerned about you.
Yes.
Right? I'm concerned about Mary and Bob working the NIC unit, and we're concerned about the work you're doing. We're concerned about your mental health, and we're talking about it at what you think is an upper level, which really isn't. It's more of an outside level looking in upon you and making sure that we value what you're doing. Right? That type of stuff.
Those are the first two wins we always think about. And I mean, it goes back to that conversation you and I had where we sort of inverted the organizational chart to put the employees at the middle of how we can support them as management team. And we think about how we can support the employees and then how that improves patient care. Those are the first two big wins. And if other things happen on our win list at the same time, right.
We do speak to that. Like,
That's
on a
great.
regular
Like
basis. I know, for instance, in CP, I have spoken to that on a number of occasions.
Yeah.
About the investment in the Waterloo station and all the different ways. It's really supportive. So that we're getting that.
You guys all came up to, right? It means a lot when you know your boss is talking about you and appreciate you.
Completely agree.
And you would agree that there's more, I think everybody around here would agree that there's more eyes on what the board's doing than ever before, because we really didn't, as a board, didn't do a whole lot before, but now this is where the action is and they can. I talk to paramedics every day and they can sort of see 3 months out, 6 months out, a year out, and then think about how that for the newer employees, they think about how that affects the longevity of their career. And for those that are more senior, they get to sort of see what's coming and what it means for them as well.
Yeah. And the value that's placed on their experience.
Yes, yeah.
Okay, if there's nothing else, we need another motion to accept this for information. Kathy and Susan, all in favor? Carried. Next one, Dan, it's yours, and I understand you're gonna give us a movie.
Apparently, yeah, we're gonna. Little productive.
Charcoal. We have to go back to the share. Yeah, go back to the Zoom. He gets the big chair and he forgets how to run the thing. There you go.
Do we have
Just
John
share
back
it.
in Boston?
I was just need to move John back on.
John's there.
Oh,
He's
he's
just his
Oh, okay.
videos.
Oh,
Okay, just the
Yeah.
videos on, okay.
Yeah. Maybe Dan will speak to it before we run the video.
Sure, I can do that.
Alright.
So, what you're about to see is a new diagnostic tool that we've placed in the CP program. So for a little bit of background before I tell you about this diagnostic tool, so you understand what we're doing with CP. One of the core features of the community paramedics expanded scope of practice is point of care testing. Some time ago when the community paramedicine first came on board early in its development, the first one that came along was a point of care test for kidney function. So it's very specific. It's a cartridge based on a device at the patient's bedside, whether that's in their house, their apartment, or in a long-term care facility, as we're doing now with L2C+. So that's where point of care testing sort of started. That was kind of the birthplace of it. In the past year, we've expanded that to include 3 other tests out of the same device. So now we can test for lactate levels, which will tell us if there's a systemic infection in that patient. We can test for blood clotting factors so that we can determine how are they doing with their anticoagulants, as an example. We can also test for diabetes. So we can test for in terms of how are the diabetes tracking over the last 3 months. We can also test for, are you pre-diabetic? Are you heading in that direction? So that's where we stood up until this point. And about 6 months ago, I came to Adam with the notion of CBC testing. CBC is complete blood count. What I had noticed in most of the orders that we were getting from physicians going back many years, in fact, they were always asking for a CBC count. And we were consistently saying, sorry, we can't do that. With the reason being that for many years, the technology just wasn't there to enable a point of care test from a CP scope of practice perspective, because this is a laboratory test that typically if a doctor wants a CBC test, you're going to go to DynaCare, you're going to go out to Life Labs, and they're going to put it in a centrifuge, which takes up a desk space like this, and a laboratory technician is going to handle that. And there's safety issues with that, et cetera. They're an open tube system, so you have to be very careful. And there's a lot of procedure that's involved with that would not suit a community paramedic. So when I began to investigate what was available out there, this is the device that we eventually settled on from Sysmex. They are a Japanese company, a global company. They are industry leaders in these devices. It's about the size of, remember the old hard drive towers? It's about that sort of a footprint at our Waterloo station. We're adding this to what we call our point of care testing, even though it's not truly point of care, because essentially the way this would work is that the community paramedic would go to your home, draw a small vial of blood, and then take it back to the Waterloo base immediately, put it in the device and test it. So it's practically point of care testing. Recently, we had a point of care test because we just started this last week, and one of our very first point of care tests with this was down in Newbury. So we had to test that out and see, well, how quickly can we get that to the physician, because the blood is only good for 4 hours, is what we were told. And I'm pleased to report that from the time it was ordered in Newbury to the time we got the test results to the physician, it was 2 hours and 15 minutes. So this model is going to work throughout all of Middlesex County and the city of London. Yeah, very So in essence, we have now expanded our ability to provide even more comprehensive service to these patients and to the physicians who are ordering these requests. So what exactly does the CBC give the physician and the patient? The CBC is a very broad spectrum test, actually. It will tell you, it can screen for many conditions. It can tell you about your general health and how you're feeling. And particularly for our senior population, it's going to speak to causes of symptoms. Could be swelling, bruising, bleeding, fever, weakness. All of these things can be explained through a CBC count done by way of this wonderful device. It really greatly enhances and facilitates these physicians' ability to arrive at that differential diagnosis to say, this is what's going on with Dan today. This is why he's feeling the way he's feeling. It also goes a long way as well towards explaining or helping to further the care in an existing patient in terms of, do we have the right medications prescribed for Dan? Do we need to change those medications? Do we need to change the dosages of those medications? Do we need to add medications? So the those other tests that I explained to you that we had started with are very good for specific conditions. This opens up the door to a lot of other situations. So this really greatly enhances the physician's ability to arrive at that differential diagnosis and arrive at it earlier. The spin-off benefit to this as well is the way in which it's going to impact our system. Because oftentimes these patients, if the physician determines it's somewhat of an urgent need because they are deteriorating or they've got the new signs and symptoms that are worthy of investigation immediately, and I can't wait for Dynacare or Life Labs a week from now, 3 days from now, they're calling an ambulance. And an ambulance is going to take them into the hospital to get squirted.
And back.
And back, yes. There's going to be 2 trips involved in it. Can you envision Newbury? That's
That's a day.
That's a day. That's a long drive, and that's a lot of time tied.
And Dan, isn't there a worst case scenario where, because we're able to do this so fast, and get results so fast, sometimes if patients have to wait, it could even be their condition could worsen in the time period because there's a secondary test
Absolutely
that
correct.
might be asked for.
Absolutely
And
correct.
then that's another ambulance call because the conditions worried while they're waiting, got worse while they're waiting for additional results.
That's right, and that's
You could be looking at more than one ambulance trip.
you could be because oftentimes what can happen is that they will take the patient in to get the test done, and don't forget the patient may wait quite some time in hospital for that test.
Right.
Gets the test done, we'll get you the results. Call for transport back home. Oh, here's the results. This is the condition. It's really not good. We need to have you back again. Back you go again. So there's another trip.
So we're working hard, like the innovation of the group that's working on all of the programs is just incredible. I've been really impressed with how, but this is something that I think is going to be a real game changer for our rural and small urban population.
Absolutely.
But also, the hospitals are excited about this. Our community paramedicine folks are excited about this. And then from my perspective, if we can eliminate, 2 ambulance trips or 1 ambulance trip, so much the better. So it's really quite innovative.
So you'll notice once we start the video, you'll notice how it's only a minute long, and you'll notice how easy it is to operate this. You don't need to be a lab technician. We also investigated safety issues. One of the reasons we went with this particular device is because it's a closed tube system, so there's no risk of biohazard. They're only basically performing a skill that they're already performing. They're taking a blood sample in a closed vacuum container. They put it into a safe transport container that we've given them. They drive it back to Waterloo Station, and you'll see in a moment how easy it is to operate this device. And I've got 3 supervisors trained to look after the ongoing maintenance. And Sysmex is incredibly supportive as well. So we've got all the pieces in place to make this a fairly smooth transition.
Now, from the board's perspective, there's a couple other things they'd want to know, like this equipment's not cheap. And there is ongoing cost. There's the reactant,
Right.
I think they call them reagent.
Reagent. As you'll see these 2 tubes, these containers next to it. One is reagent, that's the blue lidded one. The red lidded one is that's the waste product that we dispose of later. And that's an ongoing cost that we'll have to.
But if we save 1 ambulance trip, we'll pay for that for a month. Like it's just, there's a cost to it, but there's a major benefit, so.
What's that piece of equipment worth?
That
Particular, I think the device itself, I want to say was about $21,000.
I think our first,
Very expensive.
I think
I
our,
was waiting for a couple hundred.
oh, no, I think our first invoice for all the stuff was in the, like low 30s.
Yeah.
If you counted all the.
It was.
All the initial equipment and agent, and then there was training involved too. We had
There
a
was.
training day for that here.
Right.
And then, I don't know if you mentioned it, Dan, if you did, I apologize, but
Okay.
just the uniqueness of this, did you talk?
Oh,
about
I did not.
Thank
Thank you for
Yeah.
raising that point. So, we know for a fact we are the only CP program in the province of Ontario offering this. We will be the first. And Sysmex has shared with me, they are an industry leader in this device. They put this device in emergency departments, doctors' offices, clinics, lots of places. And the only pre-hospital setting that they have placed this in Canada is in a stroke transport unit in Alberta.
So, one of the things that really excites a guy like me is whenever we're first and unique, because you would not believe, to Mike's point about how important it is to be innovative to especially our new employees. They come out, they learn about all these innovative techniques in school and all the things that can be done. And if you don't have those, you're not leading edge in these things, and they go, oh, I don't know if I want to work here forever. And I was really excited because a paramedic that I talked to a lot, he's over at the Byron station. I really have a lot of time for hearing his thoughts. He was telling another paramedic in my presence just how innovative we were trying to be and how we were trying to push the envelope. And he's been in other systems in Peel and other places around. He said, you know, this is up there now and getting further away. So I really like that it's not easy in this business to do unique things and to lead. And Dan's team is doing that here, so they need to be applauded for that. And we think it's gonna be great. So movie
The
time.
paramedics have responded really well to it. They're excited. And I think to speak to Adam's point earlier about the fact that paramedics want to help, they want to serve and they want to help people. And I think it's been frustrating for CP paramedics over the years to have to keep saying on those requisition orders when they're on a conversation with a physician, I'd like a CBC. No, I can't do it.
So one of the
Now we can
things,
say yes.
one of the things that we're looking at too is whether or not, like our one base at Waterloo is right, or whether we need another CP base in Strathroy, because Dan and I both were concerned about this. You're gonna hear them say in the video about the 4-hour time limit. And it is a challenge, and especially with that county, the county is big. And so we're thinking about whether if this works, then what does it mean for like maybe a Strathroy station that's central to the county? Because this is right in downtown London right now, and just downtown London itself
So,
can
track it at 4 hours.
There's depending on the time of day.
yeah, we want to make sure that
He's
we
thinking the same thing.
respectful of that 4-hour time.
Yeah.
So why don't we see it all and
The
then
following video is a demonstration of the Poach 100i hematology analyzer. First, a blood sample must be obtained by venipuncture. Once the blood is drawn, a community paramedic has 4 hours to return the sample to the device for analysis. The community paramedic inserts the sample tube into the holder, adds a health card number for patient identification, and pushes the run button. The machine runs its analysis and provides the results in approximately 3 to 5 minutes. The machine will alert if any values are out of the predetermined ranges. Once complete, the machine prints a receipt of the desired blood values. Following this process, the community paramedic will report the values either by phone or fax to the requesting physician for further consideration.
Pretty easy.
I'm surprised that it doesn't automatically have the ability to automatically send.
But it does actually. It does have that ability. The problem that we later encountered was with the specialized server software that is used by labs for that and the subscription costs associated with
yeah,
that.
so there's a little bit of a
So
hiccup there in terms of
Yeah.
what that costs. And so we're gonna do it this way for now.
for now, yes.
And then we'll see, first of all, the price of that function might drop, and second of all, we might have some other, we found it a useful, like Dan and I originally thought, oh boy, this is a deal breaker. But we were able to find a workaround, and we think that we'll be able to either modify the workaround to be even better, or the price will come down to the point where it's more affordable.
And transcribing as they're going to do now from to transcribe those results now. They're doing that now from their portable live stat unit that they use for the other 4-point encounter
Right.
tests. So there's nothing outside of scope of practice or usual current best practice. There's nothing unusual about doing it this way for now.
Right.
But it does have the capability. We just have to kind of figure out what that workaround will be later.
Just on the cost of it, is it considered a capital cost? Can it be can it be funded through our CP funding, or is this,
As we did.
We can fund it through CP. It's through CP, yeah.
But I think, you know, just on that point about CP funding, we could do double the amount of CP funding and still not meet the need. So yes, that's where we got this money from, but it's not because we have slippage.
no.
We could easily go over all the time in CP budget. We have to pull other things out of the 911 just to support CP where they are. But
Well, no,
that-
just my point is like, I think, you know, pat you on the back, but I do think particularly our CP program is very service driven, right? Whereas maybe some of our neighboring CP programs are more capital
Oh, I see.
focused.
Yes.
And then I guess I was just unsure if this could still be funded through that, or is this something that we would have to purchase on our own? That's
You just wanting to get that advertisement in there. Absolutely.
Like,
No,
to that point, you know, how is it that we can deliver the service better? What else can we do
Well,
to enhance it? We are incredibly service.
I
What
think
we're
there-
trying to do is double down on that core mandate.
Yeah.
CPLPC, that's what we've done for the last year and a half. We've tried to really, let's become really, really good at this core mandate that the province has asked us to deliver.
So when we get more time, Brian, we're gonna do, Adam and I and Dan will do a report for you too on the changes that are happening in funding at the CP level and what it all means, cause I think there's some more details we can provide you on what we're doing versus what others are doing versus what the province is looking to try and fund and the new type of funding model that putting in place. We wanna give you some more details on that. Because again, that's where the board's gonna be really valuable, and I think a bunch of boards can be really valuable to advocate for certain types of funding for CP. going forward.
Well, when you see, you kind of go, why aren't others doing this? You know, you really do, like, I mean, this is exceptional. But I think your report will answer to the question that you're asking about
Mhm.
what's capital and what is, how things are getting funded. I think that would be good to hear. Yeah. Wow. Any other questions on it? I mean,
No, it seems great.
If I could just add one more thing so you understand the impact of this on the LTC Plus pilot program side.
yeah,
I came to understand through this process, how do they get the CPC results for their long-term care residents? Essentially, most of those homes, they have a day, maybe two if they're lucky, if they're a large home per week. And they book as many people in as they can, and Dynacare or Life Labs, or whomever they've contracted, will come in and try to get them that help. And if they're overbooked, too bad, you have to wait another week. And that also doesn't factor in the point that they're usually waiting sometimes days or even up to a week before they even get the results as well.
and
So on the
to your
LTC
point about
Plus
things
side, we're
getting
gonna be-
worse.
Right.
Ambulance
To your
trips.
things about.
And then, correct, then that's where more ambulance trips come from,
Yeah.
and now we're inserting this into that process. So
Good,
they're very excited.
thank you, Dan.
That's an interesting business plan,
Mhm.
thinking about long-term care homes.
Mhm.
It would be available to the LTC Plus partners, yes. And as part of that pilot point of care testing.
Can you take this and go mobile with it? Like, could you take it to a long-term care home and? say,
No,
"Oh, we're here
this
for the day"?
unit has to, it's calibrated, so it has to stay.
We did think about it, like, it was something we had a good talk with the vendor about, but, it's just not worth the risk. Especially if we can do it this way,
And we wanna make sure they're accurate,
yeah.
right? We wanna make sure everything's.
That's right.
So what, I'm just curious, so what is the calibration? I don't need specifics, I'm not there, but what does it take to calibrate it? What are you talking, half an
In
hour?
time, you
20
mean?
minutes, yeah.
Yeah.
Oh, in terms of time, initial calibration, I think it was close to an hour to get it calibrated before we could start using it.
But also, it's
Is that what it's
not
it's
done
a
by
technician
us.
does it? Yeah.
Oh, you guys aren't trained
No.
calibrators.
No, it's not a plug in and push a button and it
No.
calibrates. Now, next models probably will be,
Mhm.
Yeah.
but this model isn't. And so I just, I was, Dan, I think Dan and I and Adam were all on the same page. Put it there, get it right, and then we'll look at
Oh,
the.
and it's amazing, I just, my mind's running
Well, wouldn't
rampant
it-
about
Mhm.
It'd be great to
$30,000,
have it
where
at the
can
back
I
of the
put these and how
CPC.
can I save money? Wouldn't it be great to have one sitting at a long-term care home where even if we have to send in a community paramedicine person to take all the vials of blood and boom, and we're done. And if we're saving money, somebody's gotta be saving money by not having Life Labs or Dyna
Dynacare,
come in and do it all. They won't like it.
As we talk about at the point
Hopefully all our money.
of a second unit at another location at the other end,
yeah,
that
We'll
is
keep
very
monitoring.
viable.
We'll keep monitoring the technology and seeing how this goes, but. You know, I like to stick that toe in the water, get some data to support all this. Right now, we have anecdotes, but we're monitoring the data really, really carefully so we can prove to the board and the public that we're saving you money, giving you a better service with this. So then we'll go to the next two steps.
Yeah.
Yeah, sounds like you're gonna be busy.
I think so.
Yeah, so that was.
The response has been very, very positive.
Okay,
Excellent. We need another motion to accept the report. Mike, Susan, all in favor? Okay. I think that's our last report, so correspondence and information items, we don't have any. We are looking to go into closed session. So we need a mover for that. Kathy, Susan, all in favor? We're going to closed session.